Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, I'm Becca Catlin, and I'm a full-time clinician in Seattle, Washington. I am involved in the AAOMPT Research Committee, and this allows me the great privilege of interviewing outstanding people in the field of physical therapy. Our guest for today, who is one of those outstanding clinicians and instructors, is Alec Kay. Alec has been practicing physical therapy for over 25 years and currently works full-time in the clinical practice at United Physical Therapy in Anchorage, Alaska. He is the current president of that organization. And working as an athletic trainer prior to PT school, he continues to enjoy working with athletes. His postgraduate studies include completion of a Master's of Orthopedic Manual Therapy in 1997 and a Doctor of Manual Therapy in 2000, with a dissertation on the lumbar multifidus leading to multiple publications. After completion of his DMT, Alec was appointed to the faculty of the Ola Grimsby Institute Post-Professional Consortium and is currently teaching advanced techniques in manual orthopedic physical therapy locally and in other states, as well as presenting as an invited speaker both nationally and internationally. In addition to teaching, Alec shares his expertise working as a clinical mentor of residency fellowship students in both manual therapy and family practice medicine. Dr. Kay, welcome to the American Academy podcast.
Thank you very much.
This is one of our episodes where we're highlighting our membership who have presented courses at our conference in Reno. So to start this off, Alec, why don't you give us an overview of the class that you taught?
I'll do that, Dr. Catlin, and thank you very much for inviting me to have a conversation with you on this topic. Brian Power and I, developed this course with the goal of using case studies to teach manipulation techniques and just as much to talk about communication with patients and how we can manipulate, no pun intended, and sort of optimize outcomes based on how we communicate how these techniques are expected to help. And so the topic or the overall theme of the conference this year was changing the pain game. And so in addition to the manipulation techniques, we wanted to really focus on communication and healing messages and how to really optimize sort of the role of these techniques in people's recovery.
So when you were deciding to put the class together, what were the needs or the holes that you saw that prompted you to head in this direction?
One of the major issues that we were trying to address is the fact that, with the latest really impressive and incredible research on pain education and pain science over the last 5 or 10 years, that's really dominated a lot of physical therapy and specifically manual therapy. Predictably, there was a move sort of away from manual therapy, thinking that it could be even creating some catastrophization with patients in terms of using language that is giving them images and issues that they're kind of focusing on. And we wanted to help give examples of how manual therapy has its role and can be used right in conjunction with a lot of this research that's come out in terms of pain education and how it can improve people's autonomic nervous system and their perception of pain and their whole emotional experience when it comes to pain. That was really what we were trying to address with these techniques and combining the language and the education with the skillful application of manipulation.
I'm really interested in how you are combining manual therapy with folks who are in chronic pain and the neurobiology behind that. Do you mind getting into a little bit about how manual or manipulative therapies affects the body and how that also can be beneficial for managing chronic pain? Like, how do the two fit together?
Well, one of the things that we really focused on was the aspects that have come from research that was done in the Harvard Medical School lab, and the primary authors that have been speaking about this were Randy Golub and John Kong. And they did some fascinating research using functional MRIs with expectations of outcomes. And so, looking at what areas of the brain are reacting based on expectations can play a huge part in terms of if somebody has benefit from a pain relieving technique or not. The title of what they talk about is the difference between a placebo and a nocebo. And placebo for years, at least early in my career, was always thought of as something that you didn't want as part of your treatment because it sort of clouded your ability to make judgments in terms of the utility of a certain technique. But I think as any clinician who's working face to face with patients, you are doing everything you can to light up regions of the brain that are going to help people's pain experience and then hopefully enable them to incorporate better motor patterns and have less kinesiophobia and basically improve their function regardless of what's happening with their tissue. With the studies that they did using functional MRI, and they were using anesthetic administered intravenously, and they had three groups of patients. The first group had basically the expectation was we're going to apply this slow onset of heat to your finger, which creates a pain experience that is nociceptive because it's related to the amount of heat that's applied. And here is this morphine, and it does a really great job in decreasing the pain. And so when they looked at the functional MRIs and they had that positive expectation, the pain experience was significantly decreased as opposed to when they had the same amount of morphine and the administrator of the test applied the same amount of pain stimulus, but they said, we have morphine administered in this IV, but unfortunately, this hasn't really been helping people very much. In other words, giving them a negative expectation. And what they see with the functional MRI is a completely different experience and minimal pain inhibition with the same amount of drug. And so, taking this information, when you're applying manual therapy or any kind of intervention, having a positive expectation with your patient is crucial to get the outcomes you want, to get the functional changes that you want. And so there's the mechanisms that you referred to in terms of the local mechanisms of manipulation and how that can change the nervous system, but we're trying to also take advantage of the central mechanisms that can basically optimize your techniques and ultimately your functional outcomes. And so that was a big part of how we were talking about communication and giving, positive expectations that are also realistic.
So, to be very simplified, the patient's belief is paramount, and what they experience is their outcome and their ability to experience a different level of pain.
Right. And there was several different outcomes, or I should say, I guess, pathways that happened during this, what I would consider the latest exceptional research in terms of pain science. And one of the main things was there was an article published in the Journal of Multidisciplinary Healthcare by a physiotherapy professor from Curtin University, Max Zussman, and his opinion, which was well founded, and you could understand why he was writing it, but he was basically making the case that manual therapy is one of the reasons that low back pain has not been successfully treated because of belief reinforcement. In other words, he was saying that manual therapists are focusing on telling the patient, oh, you have this asymmetry, or you have this pathology, or you have this degenerative issue. And even though I'm going to treat you for it, you're still conveying these negative issues. And so that is basically belief reinforcement, which is similar to a patient, maybe going to their primary care physician who focuses on the pathology they see on the x ray or the MRI and giving them that nocebo effect with this negative reinforcement. So Dr. Zussman's conclusion was, manual therapy is bad for low back pain because it's giving this belief reinforcement. And, having been in the profession long enough to see some trends swing a pendulum in an extreme direction, it wasn't surprising for me to see that. And it was so rewarding at this conference to have presenters like Adrian Lowe and Louis Puentedura and his group with Steve Schmidt talk about really how manual therapy, when it's done correctly, not only from a handling standpoint, but also from a communication standpoint, has still an extremely powerful beneficial effect if it's done correctly. That is how we're trying to work with the expectations and avoid creating a nocebo effect by focusing on pathological tissue more than is appropriate for every individual.
What comes out of a physical therapist's mouth is potentially as important as what they do with their hands. Your course was titled Using Skillful Hands and Healing Words to Win the Pain Game. Can you give us an example of what is a healing word, how you'd positively say something versus something that could be counterproductive?
Absolutely. The way we did this in the course was, as I mentioned earlier, we used 5 different case studies so that we could have a patient scenario that would help the students kind of understand how we would do this. So, for example, one of our case studies was Main syndrome, or pain referred to the Fortin area, the SI joint area from the thoracolumbar spine. The way we would, when we do our evaluation, which is, needs to be very thorough and tissue oriented, but when you find the characteristics associated with this syndrome, instead of saying things like, oh, you have this degenerative joint here at your L1, L2 region, you have significant muscle spasm that's causing this referral of pain, where, you don't talk about how you have this damaged back or this injury or your back is weak and that you need to avoid doing things. It's more using words like, oh, you have this little irritation here in this region of your back that can be significantly improved if we just get the motion normalized a little bit, encouraging them to, I guess, open their minds and have a expectation of improvement based on what we're doing, repeatedly assuring them that, this isn't a long-term injury. It's a little sensitization issue that's happened based on your posture or the way you've moved. But these are things that these techniques will help you feel a more normal motor recruitment pattern and move a little more efficiently so that you can kind of normalize it and move forward. And, this is what you saw on the x-ray maybe is not really meaning that, you're on a spiraling downhill course. It's just some irritation that we can work through. And these techniques will just kind of move us one step closer for you to be able to take care of it.
So the key is painting a picture in the patient's mind that their condition is not fixed, that it's changeable and improvable, and creating that sense of hope.
Right. Yeah, that's a big emphasis in the way we use our words, because there's kind of a saying that we like to lean on, and that is, where there's no hope, there's no healing. Because I know you, Dr. Catlin, work full time as a clinician, and if you can't change that little belief in a patient that they've got potential to get better, you've got such an uphill battle in terms of getting them well, and so you're always creating hope. If your manual techniques are done in a skillful way, um, they'll feel the hope as well as hear the hope in terms of your words. So that's kind of the combination that we're trying to emphasize. And this style of using case studies, I think, was the first time we did that. And I feel like it was very beneficial because it just gives the students a better picture instead of just talking hypothetically. We could use specific regions of the body and talk about how manipulation techniques, extremity or spine, would play a role in terms of these specific problems.
That's great. You mentioned skillful manipulative techniques, which brings up the question of, does the technique matter? So if we're affecting the patient's central system, their brain, setting up a sense of hope and a sense of belief, tell me how you decide what manipulation to do, and if the manipulation, which one you pick, is how important that is.
There's lots of evidence that has shown that for certain patients, the technique you do probably doesn't matter. If we're talking about a patient who's primarily in the model of biopsychosocial, neurophysiological, if that's kind of the model that they fall into, then a general technique and a regional technique is probably not real important in terms of specifically what it is. But we have to remember that all of our patients don't have this big biopsychosocial component. Everybody's got a little bit of it. Everybody's got, a neural component, but some of our patients are biomechanical patients. And that's something that I think has been really de emphasized with this new emphasis on pain science. When you're learning techniques, you absolutely have to have the background and to be specific when you need it. Because otherwise, you're only going to be doing general techniques and you're only going to be helping those patients that fit in that model. But if you have a patient that needs something very specific based on their tissue, that's where you need the skill to apply it, and you need to be able to apply it in a gentle way so that it's more comfortable and beneficial. So the technique absolutely matters in certain patients, and that's what improving clinical mastery is all about, is about how do you help the most patients you can. If you learn one technique really well, you'll be able to help that model of patient really well. But the other half of your patient load isn't going to be happy. And so the more expertise you develop on all the different models of patients that we see and all the different varieties of techniques, the more benefit you'll be able to deliver for your whole patient load. And that's what this course is about, is how can you help more people more efficiently.
I think this is a great differentiation of the central sensitized person in chronic pain versus many of our patients that have active tissue injury. If we take the case that you had mentioned, the gentleman with thoracolumbar junction syndrome, describe how that patient has potentially a component of heightened neurological increase reactivity at that level. So there is a neurological component, but also a mechanical component. You can unpack that a little better than I described it, but where the two kind of meet and you have a little of both.
Right. Well, I mean, for this patient, in my experience and in Robert Main's original description, there usually is some sort of tissue pathology related to a facet joint. Now, that's not always going to be the case with a patient who has this referral pattern, but with your question, it would just be a good example if they did start with some sort of maybe change in mobility if it's a hinge point and they get a little excessive compression on a facet joint to cause a little irritation. So that's kind of maybe the initial trigger and a biomechanical thing. For that biomechanical issue, you may be doing a manipulative technique, not really at that segment that's creating the pain, but maybe at some higher levels in the thoracic spine to change the mobility there to take stress off of that hinge. Now, at the area where there's pain, at that segment, that's a neurological scenario where you can use a manipulation at that segment or above or below it to decrease the neurological output that is leading to the syndrome itself. So that's what leads to not only the referral through the cluneal nerve to have pain at the iliac crest and Fortin's area, but also to get the typical muscle guarding, potential positive skin rolling effect, and just the hypersensitivity. So you got a biomechanical problem there that has kind of overflowed from maybe facilitation of that segment to create some motor changes and some cutaneous hyperalgesia from the neurological system. And that's not even taking into account the biopsychosocial effects coming down from the more cranial regions in terms of descending sensitization with maybe fear of disability based on other things that have happened in their life, maybe other injuries that they've had, other traumas, psychological, emotional traumas that somehow been connected to low back pain. I mean, that's where it gets so exciting and interesting dealing with our patients, because you have this individual who has all these different components affecting their primary complaint, which is pain in my hip. You have to look at the whole picture, and that's why the skillful hands part is the manipulation without irritation, and the healing words part is being able to listen, have that really exceptional therapeutic alliance, and use words that are going to give this patient the opportunity and direction to make some really positive changes. So that scenario is not uncommon. It's not unique to this diagnosis. It could happen anywhere and all over the body. That's what we're trying to do, is deal with all those different aspects.
Thanks for bringing the case study aspect and unpacking that a little bit for us. What thresholds do you have for screening patients for appropriateness for the various techniques?
Well, obviously, there's the simple red flag contraindication kind of things that go along with all manipulation, and then beyond that, there's the just sensitivity of the tissue, locally and regionally. That comes from your evaluation. Everything in your flow procedure, from palpation to mobility testing to looking for sensitization and facilitation in different areas. And so, depending on the skill of the practitioner, there's more opportunity to do techniques when you have more skill, because you can do it more gently and you can do it more specifically, and you can do it in ways that can affect, from a distal segment or proximal, to affect that area. So it's it's not a real easy question to answer, because there's so many different subtle things that go into determining who's appropriate for manipulation and who's not. Those are some of the basic things.
What are some missing links or holes that you often see in PTs when you're teaching this content? So what are they missing?
Well, I think a lot of the PTs that take manipulation courses, the missing links could be one of two things. One could be they just simply don't have the familiarity or the background of high velocity techniques, and they might have a real significant apprehension or trepidation in terms of doing high velocity techniques, which is something, that we need to work through, and is, in my opinion, it's fine if you don't have the experience. It's better to be that way than to be overconfident. So that's one thing, is kind of just repetition and understanding the histological effects of manipulation and how speed can make your techniques safer, and obviously keeping your amplitude down. And then I think the other hole that I see a lot is the other direction, where people are a little bit cavalier depending on their experience or their training, where they, in my opinion, don't have enough respect for the tissue and the need for specificity when it applies. I mentioned that, it's not always necessary to be specific, but if you're only able to bring a big hammer and get a big result, but you don't have a range of techniques and a way to be specific, that's going to really diminish your outcomes. And it's also going to not help the profession if you're doing techniques that aren't as beneficial. I mean, what we want ultimately is an association with physical therapy to better outcomes. And so anything that's not working in that direction, isn't helping us as a whole. So I would say, it's either people are a little too fearful, or they're a little too cavalier or too general, and just trying to get noise from a joint and not thinking about the details and the specificity.
Do you have anything else that was paramount to your course that I haven't asked about that you'd like to share?
One thing, again, this is kind of getting a little bit repetitive, but I feel like one of the things that was really important with our course was looking at the regional interdependence of different body systems in terms of how they can be used with specific case studies. We had a cervicogenic headache case, and so we talked about how manipulation in this case could be done in multiple regions, not just the upper cervical spine, but also the upper ribs and thoracic spine, and how you can get significant inhibition of headache from those areas. We had a case of a painful disc herniation in the cervical spine, and how this could still be a manipulative candidate if you approached it from a regional interdependent standpoint, looking at improving tone status in the thoracic spine or even the upper cervical spine. And that's where really good technique is important when you have a pathology that you're trying to protect. We had chronic knee pain, lateral elbow pain, just talking about how going to the wrist to do some manipulations of the carpal bones. There's great research in terms of having benefit from that. Addressing the mechanics of the wrist or neurologically providing some inhibition can significantly decrease strain with the lateral epicondylitis, for example, and all the way up to upper thoracic spine, C6. That concept of how you don't have to just treat at the area of the pain, and using the regional interdependence concept from both a neurological standpoint and biomechanical, I feel like that was a valuable part of our course that the participants seem to respond well to.
Yeah, a deep understanding of neuroanatomy and the overlap is certainly helpful. Understanding how the sympathetic system and its map plays into how you can create inhibition and affect regions that appear to be not associated. Neuroanatomy is very foundational.
Right.
Do you have any other projects or anything in the pipeline that you're currently working on?
Nothing really different than continuing on this current path of giving interested physical therapists the opportunity to really master their skills. I think that manipulation manual therapy has been around since the beginning of time, as has neuroscience or pain education. That was another part of our presentation that we just like to point out, is that the packaging right now for neuroscience is really fantastic in terms of utilizing it with patient care. But since the beginning of recorded medical history, from Cicero in 100 BC, making comments that emotive factors can give rise to physical illness and that man can help his own cure through philosophy. Quotes like that are important to acknowledge, that as medical professionals, as healers and helpers of people, we're not inventing something. We're just studying it in a way that's easier to, I think, process and understand. But getting a little bit sidetracked there, my goal and the people I work with at the Ola Grimsby Institute is taking interested physical therapists who really want to just take their whole practice to another level in terms of efficiency. And even if you're a fellow trained physical therapist, there's always room for improvement in terms of mastering your skills. That's why it's been really fun to be part of the American Academy conferences, because usually in our workshops we get a variety of practitioners, some that are just getting interested in manual therapy, and others that are maybe teaching manipulation, but they have that hunger to just get a little bit better, change things a little bit with their stance or their body position, and have a better outcome. And it's a great path to be on, to just constantly be trying to improve your skill and your craft. It's really what makes it that much more rewarding and fun. And continuing on that path of teaching and perfecting the techniques and integrating all the science that we have to support what we do, and to sometimes give us new ideas.
Well, that's a great segue to how might people get a hold of you if they wanted to learn more, pick your brain, or take a class from you?
Probably the easiest way to get a hold of me is with my email. It's just my first name, Alec, ALEC, and it's at unitedpt.com. That's where I practice in Anchorage, Alaska. And on the olagrimsby.com website, there's also places where you can ask for information and get connected that way.
Alec, thank you so much for coming on the podcast. It was a pleasure to speak with you, and I look forward to seeing you at the next American Academy Conference.
Thank you very much, Dr. Catlin. I really appreciate all the work that the research committee does in terms of keeping us on the forefront of science. You guys are a crucial role for the academy and for the profession.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.